Good morning, everybody. I hope that everybody is well today. And today, what we're going to discuss is family planning. Now, family planning is an extremely important concept for pharmacists to understand and to take heed of. Primarily because family planning, for the most part, is actually revolves around contraceptive hormones in most cases, some of which you will be very familiar with your time in the pharmacy. There's also a way in which you as a pharmacist can prescribe contraception as well, and contraceptive prescribing is now the big thing that is happening in the United States of America, for example, which is something we'll discuss later on, but it's something that has been happening in South Africa for a long time. Provided you do a family planning course that is registered with the South African Pharmacy Council, and you obtain a license in terms of Section 22A15 of the Medicine and Related Substances Control Act, you can then prescribe certain family planning methods, such as the combined oral contraceptive, the progesterone-only pill, and of course the injection contraceptive. As a result of that, this particular area of study is extremely important for you to understand, right? Oral contraception by far still remains the cornerstone of family planning, and it is the method that majority of women use, right? It is therefore extremely important for you to familiarize yourself with contraception and contraceptive hormones in detail. Over the coming number of lectures that we have together, we will not only discuss contraceptive hormones, but we will also discuss combined oral contraceptives, progesterone-only pill, combined patch contraceptive, progesterone injections, intrauterine devices, the levonorgestrel intrauterine system or intrauterine device, for example. The progestin implant is another thing we will discuss as well. We will not spend so much time in fact we will not discuss the vaginal ring because it's uncommonly used. Even though it's a form of combined oral contraceptive that is actually placed inside the vagina itself, it's very uncommonly used in South Africa in particular. Another thing that we will discuss is we will discuss specific clinical situations in which you will prescribe a specific type of contraceptive to patients. We'll discuss how to provide an emergency postcoital contraceptive service, how to provide a reproductive health service to patients, including how to pick legitimate types of family planning or contraceptives for the patient. Now, when I say pick, I don't mean you pick for them. I mean you explain to them so that they can learn how to pick for themselves, obviously, which is very important for me to say. And then, of course, the last but most important thing which we're going to discuss is dysmenorrhea. Now, you will notice that your handout with all your notes is fairly long and fairly detailed. Now, unfortunately, in order to provide you with a really good grounded understanding of this particular topic, it requires me to actually have such a lengthy set of notes. So let's get started. Now, you know that reproductive physiology itself centers around the hypothalamus, the pituitary, the ovaries, the vagina, etc. In the case of a woman. In the case of a man, primarily the hypothalamus itself, and then the pituitary, and then, of course, the testes. Right, now, having said that, the hypothalamus produces gonadotropin releasing hormone, right? And gonadotropin releasing hormone is then transported to the adenohypophysis in the pituitary itself, right? At the pituitary gland itself, specific hormones are released, and those include follicle stimulating hormone or FSH and luteinizing hormone or LH, as it's commonly called, right? Now, when it comes to the ovaries themselves, right, when FSH and LH actually influence the ovaries themselves, once a woman reaches puberty, right, the ovaries themselves then contain the primordial follicles containing the primary oocytes, which then develop into the Graafian follicles containing mature oocytes. The influence of FSH and LH on the ovaries itself causes the release of a follicle. The developing follicle then produces estrogen, which in turn controls the amount of gonadotropin releasing hormone. So it's a negative feedback loop, right? And this then provides both positive feedback, while negative feedback also inhibits the production of the secretion of these particular hormones. The reproductive cycle is essentially in 3 phases, and the 3 phases are the follicular phase, the ovulation phase, and the luteal phase. Now, the follicular phase is primarily controlled by FSH and to a lesser extent by LH, in which the primordial follicle itself develops and produces estrogen. The estrogen, FSH, and LH that stimulate the primordial follicle itself to grow into the primary follicle, and then finally the Graafian follicle, is what the follicular phase is primarily about. Now, the developing follicle itself secretes estrogen in increasing quantities until ovulation takes place. About 24 hours or so roughly before ovulation takes place, right, the Graafian follicle itself will start to produce both progesterone and prostaglandins. The follicular phase lasts roughly about the first 14 days of the cycle, right, in a normal 28-day cycle, but can be slightly longer depending on the person's cycle themselves. The next phase is the ovulation phase. In the ovulation phase itself, that is when the estradiol that is produced reaches its maximum concentration. The hypothalamus and the pituitary produces mostly FSH and mainly LH is released, which peaks roughly 16 to 24 hours before ovulation occurs and is essential for ovulation and the release of the oocyte itself. So remember that 16 to 24 hours primarily before ovulation occurs, you have the peak in the concentration of FSH and LH. In the luteal phase itself, right, this follows the ovulation phase and it follows the follicle becoming a corpus luteum. The development is primarily mainly via LH and to a lesser extent FSH and prolactin. Progesterone is produced with sustained release of estrogen. Now, if fertilization does not occur, and I think that this part is very important to stress, right? In the luteal phase itself, right? If fertilization does not occur, the corpus luteum can grow for approximately about 7 days and then begins to lutealize, right? During the next 7 days, it will of course shrink in nature, right? Which is something that it will do. And then when it shrinks further, it will form what we call the corpus albicans, right? And the life cycle of the lifespan of the corpus luteum is fairly consistent at roughly about 14 days after ovulation and doesn't vary that much. The regression, of course, causes a fall in progesterone levels and estradiol levels, which then causes a person or a female to menstruate. Right, the low levels will then produce a positive stimulus on the hypothalamus, and the gonadotropin releasing hormone will then be released so that a new cycle can start all over again. So I think that one thing I want to point out to you is that roughly from day 1 to day 5 is where menstruation occurs. So obviously when we're telling people or when we're telling women, like, when is the first day of your cycle? The first day of your cycle is the first day of menstruation, right? And you count from there on in. So remember that from the first day of your cycle to roughly about the 5th or the 7th day of your cycle is when most women menstruate until. It can be slightly longer, it can be slightly shorter depending on their circumstances. Remember we said that roughly the FSH and the LH will peak 16 to 24 hours prior to ovulation, and ovulation usually occurs somewhere between day 10 to day 15, right? Or roughly around day 14, most people suggest is when ovulation occurs. So ovulation essentially for that 24-hour period when that primary oocyte is released, that is when a woman is most fertile. Now that's extremely important to remember, because that is the point at which they are most likely to fall pregnant. Now essentially family planning is about trying to tell people or to help people to decide whether or when they want to have a family. Now in part doing this, you also need to be able to advise them about when is the best time to engage in sexual intercourse if they wish to have a family. In other words, if they wish to get pregnant. It's also extremely important to understand this particular life cycle and this particular process, primarily because, right, it will then come into play in certain contraceptive methods that are not as reliable but are based on understanding a woman's ovulatory cycle. So remember when we said if the oocyte is not fertilized, then you will get menstruation, because you will then get a decrease in your estrogen and your progesterone levels, which will then bring about menstruation. But what happens if the oocyte itself is fertilized? If the oocyte is fertilized, there is a sustained and increased level of progesterone, and implantation usually occurs, hopefully in the uterus itself. If implantation itself occurs within the fallopian tubes, right, remember, then you will get what we call an ectopic pregnancy, and an ectopic pregnancy is extremely dangerous. So hopefully this happens within the uterus itself. 7 days after fertilization, the zygote or trophoblast starts to then produce what we call human chorionic gonadotropin, or HCG. Now you may recognize the term human chorionic gonadotropin, because human chorionic gonadotropin is actually what we measure for when we do a pregnancy test. Now there are essentially two types of human chorionic gonadotropin that we can measure. There's the alpha form and the beta form. The beta human chorionic gonadotropin form that we measure now with the more accurate pregnancy tests that we use, well, obviously is the one that is a better predictor of pregnancy, and can basically tell you that somebody is pregnant within 7 days of them missing their menstrual cycle. Of them missing their menstruation, right? Now, the HCG is responsible for actually maintaining the corpus luteum and preventing luteal lysis, and the corpus luteum then means that the patient is pregnant, right? The growing corpus luteum will then produce increasing amounts of progesterone and estrogen for 8 to 12 weeks, until the placenta itself will take over producing the amounts of estrogen and progesterone as required. Now you'll notice here, right, that the peak in the hormone of estrogen and progesterone happens slightly just before ovulation occurs, and the same is true for FSH and LH. You'll also notice that once they peak, right, they then rapidly fall in the case of estrogen, but progesterone continues to rise, and progesterone continues to rise in this particular scenario, right, for that 7-day period, after which it will fall. However, if a woman becomes pregnant, you will have a sustained increase in estrogen and progesterone, primarily due to the effect of human chorionic gonadotropin on the corpus luteum itself, where the corpus luteum will start to produce estrogen and progesterone to prevent menstruation. Essentially, menstruation sheds the lining of the uterus itself. Remember that the uterus itself, the wall of the uterus, needs to be built up so that a fertilized oocyte can attach itself to the wall of the uterus itself. Now, if that wall of the uterus is obviously is not maintained, then it will shed, and if it sheds, then there cannot be pregnancy, unless of course we're talking about ectopic pregnancy, obviously. You'll notice also that once both progesterone and estrogen levels drop, there is then an increase in FSH and LH levels. That increase in FSH and LH levels will then stimulate the increase in both estrogen and progesterone. Now, the ovarian hormones itself have many other functions, right? Estrogen, for example, has many functions that are involved in reproduction, but also has influence on things not directly responsible for reproduction, particularly in females. So within females themselves, estrogen is responsible for development of secondary female characteristics during puberty. In other words, the development of breasts, for example, the development or the starting of the actual menstruation cycle, for example. It also is responsible for the proliferation of epithelial cells, including the regeneration and proliferation of the endometrial tissue, right, which forms part of the uterine lining. It's also responsible for preparation of progesterone target cells. It also stimulates secretory cells in the endocervix itself to produce mucus and reception to produce mucus for the reception of sperm itself and for the transportation of sperm. It also increases the contraction of smooth muscle in the genital tract to actively aid the transportation of sperm upwards towards the oocyte. It also initiates movement of the fimbriae of the fallopian tubes towards the ovaries, and it controls production by both positive and negative feedback on the hypothalamus pituitary axis. In this case, estrogen has many different effects. It affects electrolyte imbalance, right, in terms of sodium and water retention. Also, it will then affect fluid balance. It affects blood clotting mechanisms. It affects blood volume, your lipids in the case of women, vasodilation and vasoconstriction of blood vessels. It affects the skin and, of course, hair as well, and it of course is there for the prevention of osteoporosis. You'll find that when women actually reach menopausal state and they reduce the amount of estrogen in their system, they are more likely to develop osteoporosis and cardiac disease, because estrogen itself has a cardioprotective effect by reducing blood lipid levels and also by reducing blood pressure in some cases and maintaining a good fluid balance. Now, progesterone, and also it prevents clotting to some extent. When you have large amounts of estrogen, on the other hand, the risk of clotting then goes up, which is one of the reasons why we always say that women who are taking the combined oral contraceptive, we must screen them for the risk of having a clot. Now, estrogen also has progesterone on the other hand is produced during the luteal phase, and large quantities are produced by the placenta itself. Now, progesterone primarily maintains pregnancy, but it is also used in preparation for secretory endometrium suitable for implantation, increasing the viscosity of cervical mucus after ovulation, maintenance of pregnancy, inhibition of smooth muscle contraction, right? And the inhibition of smooth muscle contraction is there to prevent menstruation. And of course, it also influences the hypothalamus pituitary adrenal axis, where it influences the production of GnRH or gonadotropin releasing hormone and luteinizing hormone, and to a lesser extent follicle stimulating hormone. It's worth noting that there are some non-reproductive functions of estrogen, and that is the biosynthesis of other sex hormones, anti-estrogenic effects. It has a mild diuretic effect. It sometimes has a mild sleep-inducing effect, and of course it causes a slight increase in basal body temperature. Now, pregnancy comprises of essentially two processes, namely fertilization and then finally implantation on the wall of the uterus itself, or the endometrial lining. Now, spermatozoa are primarily transported through the genital tract to meet the oocyte and possibly fertilize it. The fertilization of spermatozoa disappears within 48 to 72 hours after ejaculation, and human oocytes are only feasible or can only be fertilized for roughly 8 to 24 hours. So there's a very small time frame window from the time a woman ovulates to the time that she can actually fall pregnant. Now, despite that, people do obviously fall pregnant. Now, if you were advising a patient, for example, who wanted to fall pregnant, one of the things that you actually have to do is to tell them to consistently maintain or to have sexual intercourse between days 10 to day 15 of their cycle. Some people even say day 10 to day 20 of their cycle, because then you will definitely get into that period of time where that the spermatozoa will be able to fertilize the ovum itself. Now, the transportation of sperm, as we've alluded to previously, essentially happens via the fimbriae, the cervical mucus, etc. But the ejaculate of the sperm itself comes into contact with cervical mucus and then coagulates within 1 minute to form what we call a coagulum, which is then liquefied by fibrinolytic enzymes. At this stage, spermatozoa themselves do not possess the possibility to actually penetrate the oocyte, and only after capacitation takes place will this be achieved. During the ovulation phase, the cervical mucus is especially favorable for the for spermatozoa. So some spermatozoa will of course reach the fallopian tube in roughly 30 minutes via swimming action and of course the contraction of the myometrium. Oocytes themselves, right, after the rupture of the follicle or the release of the follicle, the released oocyte is then captured by the fimbriae and of course transported for fertilization to take place within the fallopian tube. Cell division then takes place so that by the time it reaches the uterine cavity, a blastocyst has formed itself. Over a 2-day period, the blastocyst itself is then prepared by the uterine fluid for implantation on the endometrial lining within the uterus, and the implantation begins approximately 7 days after ovulation, and that is when pregnancy is of course set to begin. Now remember that not all pregnancies will result in a full-term pregnant baby child being born. Sometimes you may get what you call a chemical pregnancy, where the person actually will get pregnant, but the fertilized oocyte will not be able to be maintained on the uterine wall or the endometrial lining and will of course be shed. Now let's discuss of course how the different types of methods that we have. We have male methods of contraception and female methods of contraception. In terms of male methods of contraception, there is only currently one method that is hormonal, which is being tested at the moment, and that is of course the contraceptive injection, which is currently being trialed. The rest of them are non-hormonal methods. Abstinence, which is a 100% contraceptive method in that it will definitely prevent pregnancy if practiced, is the hardest of all contraceptive methods. Coitus interruptus, or the withdrawal method as it's sometimes referred to, is where a man will withdraw his penis from the vagina itself prior to ejaculation. Now there are obvious problems with this, right, that I'm sure you can think of for yourself, but we'll discuss this in a little bit more detail when we discuss conventional methods of contraception. The next method you would probably be very familiar with, and these of course are condoms themselves, and then of course sterilization is a completely permanent method. In terms of female methods, you have abstinence, which like I said is a 100% effective method but extremely difficult to practice on. Then you have your conventional methods, which include the calendar method, the cervical mucus method, the Mittel-Schultz method, the lactation contraception method, and the body thermometer method. You then have your other barrier methods that women use, such as the female condom, the diaphragm, and of course sterilization. You can use spermicides, but spermicides are primarily combined with a condom itself, either on the inside or the outside of the condom, to improve the actual condom's efficacy. Vaginal douching, which is not a very effective method. And then of course we have all the hormonal methods and non-hormonal methods like an IUD. So the hormonal methods include the oral method, the injectable method, the vaginal ring, the IUD with the levonorgestrel in it, subdermal implants or the progesterone only implant as it's sometimes called, and then of course we have transdermal application of patches which you can use, and then we also have the copper intrauterine device itself, which also can be used. And nowadays you also get what we call copper beads. These are placed inside the uterus itself, and similar to the way the copper IUD works, the copper beads work in that it increases cervical mucus production, it increases inflammation slightly to break down the spermatozoa, etc. Now, the choice of method. Now, any method, of course, is better than no method. You must take into account the patient's particular contraindications, their cultural or religious convictions that they may or may not have, their level of education as well. Now, we are primarily going to discuss how we can tell whether or not a method of contraception is effective. Now, the effectiveness of a contraceptive method is one of two ways that it can be calculated. This is just more for you to understand, but the next table where we compare contraceptive methods is extremely important for you to know. You don't need to know the numbers, but you need to know which methods of contraception are more effective and which methods are not, and depending on the scenario, we will then take it forward. So, let's start off by saying the Pearl Index. The Pearl Index itself, which is the first method that we're going to discuss, which is a method to actually determine the effectiveness of a contraceptive, is calculated using the Pearl formula and indicates the number of pregnancies that will occur should 100 women use the method for 1 year. So essentially it's 100 times 12 times the number of pregnancies divided by the total number of months of use will give you the Pearl Index. However, this is not a very reliable indicator, and it is influenced by a number of different variables that may take place. The next thing to discuss is the Life Tables Index. The Life Table Index or Life Table method measures the number of pregnancies per 100 users, which occurs using a method for 1, 2 or more years. It is thus a percentage based on the number of years. The most common factor influencing acceptability and therefore continuous and correct use of a particular contraceptive is the real or the alleged side effects, misconceptions, fears, and influences of the provider and the patient itself. Therefore, you must remain as objective as possible when suggesting a method of contraception for a particular patient. And when I say you must remain as objective as possible, you must try your absolute best to not let what you think be important. As a guideline, the following may be used. You must try and then always pick an acceptable, reliable method. Now, what we can do is that we can then look at our table of comparison for methods here, right? Now, you must take into account that as a guideline, if something produces 0 to 0.9 pregnancies per 100 women, we would consider this to be a very effective method of contraception, right? And one that produces anywhere between 1 and 9 pregnancies is considered to be effective. You must take into account that certain methods of contraceptive, when used consistently and correctly, will be highly or very effective. Very important to note, right? And then, if a particular method itself produces anywhere between 10 to 25 unintended pregnancies, that is said to be moderately effective, and anyone that produces 26 to 32 pregnancies per 100 women is said to be less effective. Ultimately, there is no method of contraception where the rate of pregnancies are considered to be over 85 in every 100 women. Essentially telling you that there is no method of contraception that is completely ineffective. So let's look at the very effective methods. Now, the very effective methods are both the ones that, when commonly used and used consistently and correctly, will produce between 0 and 0.9 pregnancies per 100 women. A vasectomy along with or female sterilization, right, will be ones that are continued beyond 1 year, because these ones are essentially types of contraception that are non-reversible. These are non-reversible types of contraception. As a result of that, the rate of pregnancy is extremely low. There are, of course, cases in which vasectomies themselves can reverse, for example, but this is extremely rare. The next thing is the copper IUD, the levonorgestrel intrauterine system, and the implant itself. These, when used normally or when used consistently and correctly, are very effective methods of contraception. The last thing is the progesterone-only pill. Now, the progesterone-only pill not only requires it to be used consistently and correctly, but it also is only applicable to being a very effective method if the progesterone-only pill is used during breastfeeding. Because breastfeeding to some extent reduces a woman's chances of becoming pregnant due to hormonal release. Combining that with the progesterone-only pill means that it will become a highly or very effective method of contraception. The next is to discuss the effective methods of contraception. Now, effective methods of contraception, right, will of course become highly effective methods of contraception, right, when used consistently and correctly, and also generally have much higher rates of discontinuation after 1 year, but are still commonly used. Now, the ones you guys will probably have heard of is the progesterone-only injection, which essentially consists of two types: depomedroxyprogesterone acetate and deponortesterone enanthate. The combined injection, which combines usually ethinyl estradiol with medroxyprogesterone acetate. Then you will have the combined oral contraceptive, which usually has some kind of estrogen and progesterone only, or that includes the estrogen patches like Evra patches, for example, or the Nova ring, which is the vaginal contraceptive ring, for example. And then, of course, the progesterone only pill, which primarily is made up of levonorgestrel. Now, I will, however, say that these methods, like the progesterone-only pill, is considered to be a very effective method, right? But it is considered to be, once again, like I said, the progesterone-only pill is normally just considered to be an effective method. However, when combined with breastfeeding, it is considered to be a highly effective method of contraception. Now, if we go down the list, we will find that progesterone-only injections are a much more effective method of contraception than something like the combined oral contraceptive or the progesterone-only pill when there is no breastfeeding. Similarly, for example, the progesterone implant, the levonorgestrel IUS, the copper IUD, female sterilization, male sterilization, for example, are much more effective methods than the progesterone-only injection, or even for that matter, the combined oral contraceptive. So I think it's very important for you to now understand exactly what I'm saying going forward. What I'm trying to get across to you here is that you need to be able to tell or to be able to differentiate which ones are very effective from which ones are effective from the ones that are somewhat effective or moderately effective. Moderately effective methods are stuff like the male condom, the diaphragm with spermicide. Coitus interruptus to some extent is less effective because it produces 27 pregnant. It will result in 27 pregnancies for every 100 women, and no method of contraception will result in 85 pregnancies per 100 women. So it's very important to understand, if you do not have a contraceptive method, the chances of falling pregnant is 85 out of every 100 women will fall pregnant. Now, fertility awareness methods which involve knowing ovulation obviously are considered moderately effective methods as well. So when does onset of protection start? Essentially, if you are taking an oral contraceptive, if you are taking it within the first 5 days of the cycle, in other words, the first 5 days of the menstrual cycle or the first 5 days of the reproductive cycle, which is exactly the same thing, that means from the first day of menstruation to the 5th day of menstruation, the onset of protection is immediate. However, if you are taking it anywhere else in the cycle, it's usually 7 days after the onset. So you need to take the tablet for a period of 7 days before you will be protected. In that particular scenario, if you are not using it between day 1 and day 5 of the particular cycle, right, and say you're starting it on day 14 of the cycle, that means the patient will not be protected until day 21. Now, in some cases, people will not want to wait till day 21 to have sexual intercourse. So you need to remind them to use backup barrier contraception in that particular scenario. The same thing is true for the injectable contraceptive method. The injectable contraceptive method, if started within day 1 to day 5 of the particular menstrual cycle, there is of course no need for backup barrier contraception for 7 days. If however it is started after day 1 to day 5, so let's say it started on day 8 of the cycle, then you need 7 days of backup barrier contraception, right? Similarly, with the copper IUD, it's immediate if it is inserted during menstruation, that is within the first 7 days of the cycle. If not, you need backup contraception for the first 7 days. Levonorgestrel IUD, immediate if within the first 7 days of the cycle, otherwise requires backup contraception. Subdermal implant, immediate within the first 7 days of the cycle, otherwise requires backup contraception. Female sterilization is immediate. Male sterilization takes 6 to 8 weeks. Condoms and spermicide, immediate onset of protection. Now, it's very important. What's going to happen is when you say prescribe oral contraception or injectable contraception for your patient, you are going to then have to advise them if it is not within day 1 to day 7 of their day 1 to day 5 of their cycle, or if you've got a nurse at your pharmacy who is inserting IUDs, for example, or subdermal implants, then of course day 1 to day 7 of the cycle, that you need to advise them to use backup contraception. Now, backup contraception is very important, and usually we say 7 days. Now, my common practice that I generally use is to tell them for up to 14 days. And that is just to primarily ensure the onset of protection. Now, that is one important thing that will consistently come up is when will my contraception start working? The next common question that you get from patients, which I often get, is when will I return to fertility, or when will I be able to fall pregnant when I stop using this particular method of contraception? Now, I just want to frame this for you to some extent. A lot of the time you're going to get younger women who don't want to fall pregnant, right? It's not for you to judge. However, you must take into account that at some point in their life they may want to fall pregnant. In that particular scenario, it is thus extremely important for you to have the discussion with them about more or less when they would like to fall pregnant. Knowing more or less when they would like to fall pregnant is something that you must absolutely do, because then you can decide on the best method of contraception. For example, if a person does actually want to fall pregnant, how in the world can you suggest sterilization to them? You cannot suggest sterilization to them. Then if they want to fall pregnant, right, but they don't mind if it takes a little bit of time, you can then suggest depomedroxyprogesterone acetate or deponortesterone enanthate, which is DMPA and DNET-EN, for example. These are progesterone-only injections. However, if they want a more immediate return to fertility, right, then you want to suggest something like either a combined oral contraceptive, an intrauterine device, or a progesterone only implant. Well, along with an intrauterine device here, you must also leave the you must also consider the levonorgestrel IUS or IUD, which also has an almost immediate return to fertility. Now, when we say almost immediate return to fertility, we mean the earliest return to fertility is once removed within 1 month they can fall pregnant. You can see, for example, if you use no method of contraception whatsoever, and I want to make this very clear, if you use no method of contraception whatsoever, most women will fall pregnant within 5 months. But the earliest time that they can fall pregnant is roughly within 1 month. Therefore, any method that allows you to fall pregnant earliest within 1 month, and of course, average within 5 months, is a method that has almost immediate return to fertility. And you can see that there are only 3 that don't have an almost immediate return to fertility, and that is, of course, depo-medroxyprogesterone acetate, which the average return to fertility is roughly 9.3 months. And particularly with depo-medroxyprogesterone acetate, women usually lose their ability to menstruate. The same is true for depo-notesterone enanthate, but it takes them about 9 months or so for them to start menstruating again, particularly if they've used it for a long time. On average, most of them will start to menstruate within 9 months. Once they start to menstruate, it means the possibility of them falling pregnant, then there's a return to fertility essentially. Same true for depo-notesterone enanthate, but slightly shorter, within 7 to 8 months after stopping it, and the average or earliest return to fertility is within 3 months with notesterone enanthate. Of course, sterilization, the return to fertility generally doesn't happen, which is why we said it is a very effective or highly effective method of contraception. And generally, it's one you would suggest to people who tell you that they are done having children and don't want to have any more children. Now, I just want to make something extremely clear to you. You must understand this, right? If somebody says that they want sterilization as a contraceptive method, you must ask them whether or not they have considered other methods of contraception. You must ask them about whether or not they have any children. You must do all the groundwork first. Some people may want sterilization now, not thinking about the future and what the future holds for them. So you must make them aware of all of these particular things, and then you must then refer them to a counselor who can then discuss this in more detail with them. Now, generally, experts agree that 66% of all fertilizations do not result in successful pregnancies because no implantation occurs, or there is early loss of implantation, and that is what we call a chemical pregnancy. Oral contraceptives are completely eliminated within 36 hours of taking the last pill. So that's why the return to fertility is the same as if no method was used. Also, it means that if you are longer than 36 hours, depending on the type of combined oral contraceptive you're using, you may then need backup contraception if you forget to take it. But we'll discuss that in more detail when we do the combined oral contraceptive. For now, let's move on to discussing, of course, pregnancy and protection against STIs and HIV. I just want to make it very clear that the only method that can protect you against STIs and HIV are the barrier contraceptive methods. Example there would be the diaphragm, or of course the male and female condom. The rest of the methods of contraception do not protect against HIV and STIs. They, however, the best way to protect against HIV and STIs is to use dual contraception, with the second method being a barrier contraceptive method, right? In that way, you will prevent pregnancies, HIV and STIs to some degree, right? Now, I just want to make another thing clear. The consideration of somebody developing HIV from a method of contraception is not topmost of your mind. When suggesting a method of contraception to a woman, you must advise her on all the possible methods of contraception, and women without HIV must be able to pick whichever method of contraception they would like. If they have HIV, this is slightly different, right? In what we'll discuss is it depends on the HIV regimen. We'll then discuss the method of contraception that we will suggest that they of course use. Another thing is to remind patients that their method of contraception will not protect them against HIV, and they will require barrier contraception as well. Also, if you suspect that a woman is at high risk of developing HIV, such for example as sex workers, so sometimes you may get sex workers who come for their for their contraception to you. A lot of them will either be taking the COC, combined oral contraceptive, or they'll be using the depot, or some cases they may be using the implant, right? You need to have a discussion with them about pre-exposure prophylaxis and whether or not pre-exposure prophylaxis is something that they would consider. Additionally, pre-exposure prophylaxis, particularly for them where they may not be able to use barrier contraception, or their particular dictates of their job may not allow them to actually be able to use barrier contraception. The same is true for certain women whose partners may be HIV positive and the partner may not want to actually use barrier contraception. And I think that that's a very important place to stop for now. And the next lesson that we will discuss the conventional methods of contraception. Now, what we're going to do at this point is we're going to stop here, and I want you to then go through the lecture notes, sit with them, and try and ask yourself the following questions. Do I know which ones are the most effective methods of contraception? Which ones are effective and which ones are the least effective methods of contraception? Do I know when the return to fertility of each one of these methods are? When is the onset of protection? If I had to advise a woman on which ones to use in terms of onset of protection and in terms of return to fertility, what would I say to the woman? For example, if I had to advise a man about, for example, condoms and condom use, what would I tell him about HIV risks, stuff like that. And then from here on we're going to discuss the conventional methods of contraception. So thank you very much for your time.